Okay, are we ready? Who's going to be first with a question? Rob has got a microphone over there, so he can. There's a person down here.
Hi there. Hello. My question is just around the polypharmacy issue. You've made a really compelling case for deprescribing, but I'm curious as to what proportion of prescribed medications are thought to be unnecessary. Certainly my elderly patients on multiple medication also have multimorbidity. And on the patients I'm particularly concerned about when I've consulted with a clinical pharmacist about what they should stop, they've been able to say, well, actually, there's nothing here. My 85-year-old gentleman with diabetes, Parkinson's, recent TIA and angina, depression and anxiety, and terrible gastric reflux is still on his 8 medications. And I'm just curious as to whether deprescribing is anything more than a new fetish catchphrase.
Thanks, Sharon. It may well be the new catchphrase, but I think the difficulty that we all face is the people on preventive medications for cardiovascular disease, for example. There comes a point in their life, at some point, when the potential harms outweigh the potential benefits. And what we don't really know at that moment is when that tipping point is, or how to sort of recognise that point. There is a point. It's not that people need to stay on those medications, for the 20 years they're lying with terrible dementia in a rest home or whatever. I don't know. I just think it's something that we do need to start thinking about in practice. And, the pharmacy medication reviews are a very helpful process, but I think we need to bring it into our daily routine, that every time we do a 3-month prescription, maybe think, does this person still need this medication, or when is the point going to come when they won't need it any longer? But I don't think we know the answers to that yet. I don't think there is good data out there about, when the potential benefits are actually suddenly outweighed by the potential harms. So, yeah, I hope that helps.
Question over here.
Hi, Tony Townsend. First of all, thanks very much, Brian and Catherine, for your presentations. I think it's an extraordinarily difficult area of medicine, which I'm sure will be leading to an increase in the statistics that Tim was talking about, because it is very difficult for us to manage and very difficult for patients. What I'm surprised about is that you didn't mention much about relative versus absolute risk, because I think this is something that pharmaceutical companies love. They love relative risk because, if you don't take our medication, you're going to double your risk of dying or having a serious event. But the absolute risk is so small that, it really doesn't make a lot of difference to an individual person. And my experience is that when you're talking with them, what actually alters people's decisions whether or not to take something is much more personal, because it's the consequences of either taking or not taking a medication that become very important to them. My mother had a stroke because, she didn't take warfarin. My uncle died because he bled because he did take warfarin. And these things, I think, are very difficult to quantify, and is why we need to talk with patients just about their individual situations. And so I think that Brian's challenge that we should assess all the benefits and risks of all possible options is easy. We can't do it. We can consider it, but we're not going to come up with an answer. Thanks.
Yeah, that's why I've raised it. We've got to have these discussions. What's really interesting is that if you talk to people who walk into a lotto shop to buy a ticket, and if they win $20, $200, $2,000, $2 million, $20 million, they're generally equally happy because they won. You become more risk adverse on the amount that you lose. Does that make sense? So I think, we need to explore these things. to just work out what they are. And I agree, we can't predict. It's still uncertain.
I think you make a good point about having those conversations or communicating with your patient, because everybody's decision is their own decision and will be different for different reasons. But I think we're perhaps not having enough of those conversations yet about, when the time might come that the potential risks for you start to outweigh the potential benefits. So, yeah, good point.
Can I just make a comment from a medico-legal perspective? Of course, we talked about the fear before, and I think really that is one of the fears that we have, that we'll do exactly as you said, we'll stop the aspirin, and then someone goes on to have their stroke the next day, and so the family will complain, and how is that going to be then perceived by the agencies that will then judge us on our actions? And I think there's a real fear that what will be judged will be the simplistic thing, which will be you stop the treatment, this then happened, and therefore there is a breach as a result, which is not fair, but it may well happen. And what we don't have is, for example, is the radiologists will know that of every film that they look, of every 100 films that they look at, on 5 they will miss something significant, and they've got good data on that. But we don't have that kind of thing for general practice. The kinds of things. How often are we going to miss a diagnosis? We don't have that data to be able to use in our defence, if you like.
Well, some people have worked out that you've got a 15% chance of getting the diagnosis wrong, or 15% of diagnoses are wrong. But, when it comes to being judged by others, or your accountability for stopping the aspirin as opposed to keeping it going, you just have to hope that you're going to be judged by people like yourself, who are aware of the risks and benefits, and we are.
I do drug-ectomies when people are having problems, my hospital colleagues do appendicectomies when people are having problems. So you look at your 85-year-old patient on the polypharmacy, and if they're hypotensive, then you stop their hypertensive medications, or you stop the medications that are increasing that risk. So it's about identifying, talking to the patient about what their life is and what their expectations are, and then altering the medications accordingly and documenting it. It's that having that conversation, which is it's a collaboration really, and if we do that, then we're safe. And I think.
Thanks, Joe. Over here, Robert.
Kia ora. More of a statement than a question maybe, and I think to something that I just noticed when it ties maybe the three of them, and even Helen's this morning about the slide had up around people wanting a relationship rather than a transaction, and I think we just overall, and I'm probably guilty of as well, working part-time, is that you start, people go to the doctor that's available, particularly in the urban areas, maybe more than rural, rather than their GP, and that transactional medicine starts to interfere with that relationship medicine, which is held general practice in good stead for a long time, and transactional medicine will put these types of polypharmacy things more at risk than that relationship medicine, which is about having those conversations with the patient and making the decision together. So more of a statement, I think that other stuff we saw this morning probably even links all three together, that how do we keep relationship medicine going when I work 2 days a week in general practice and 2 days a week in a PHO, and probably there's lots of other people in a similar position, and I think it's a challenge for the profession.
Thank you. And just before we do have to finish in a moment, I thought perhaps I might end in terms of finishing my anecdote, which fits out really well with you in terms of what happened to me with my first child. And it's very much about the relationship and about having discussions. So when I got pregnant again, I was put immediately under the care of Professor Peter Stone, who is an obstetrician, and he actually had a discussion with me as an adult and as a woman who had some intelligence about the fact that actually they couldn't do blind testing on people like me because they didn't know what the risk was to myself or the child, but they felt on balance probably taking heparin for the duration of the pregnancy was some inconvenience for me, was a good thing to do, and what did I think about that? And suddenly the whole conversation changed. I felt really empowered as a patient. I felt respected, and it was a much better outcome. And in fact, it balanced what had happened previously. So I think, you do need to give your patients the benefit of the doubt, and if you treat them well, they will really, and have those difficult conversations. Don't underestimate the ability of people to actually accept that, and actually then balance out what might have happened previously. So I want to thank our panellists. I found that absolutely fascinating. I thought the three areas worked really well together. And I'm sure there were some conversations that people want to have over lunch and afterwards with each of the panellists. So thank you very, very much.